تمام. هنبدأ الأول بال MCQ about pericardial disease. Question number 1. Pericardial cavity normally contains how much fluid? 5 to 10 milliliters of fluid, 10 to 20 milliliters of fluid, 15 to 50 milliliters of fluid, or 50 to 100 milliliters of fluid.
كده تمام يا دكتور امير. الشاشه النوتيفيكيشن دي مش ظاهره دلوقتي. كده تمام.
تمام. طيب طيب في حد جاوب على الشات نبص عليه؟
لا لسه يا دكتور امير.
طيب ماشي.
حضرتك لو حابب تختار حد يجاوب برضه مفيش مشكله، دي حاجه ترجع لحضرتك يعني.
لا انا احب انها تبقى يعني الناس تجاوب براحتها خالص عشان ما يبقاش في اي ستريس على حد، وان احنا نتكلم نتناقش مع بعض.
اوكي ماشي.
طيب انا شايف ان الاجابات منقسمه ما بين A وما بين C. طبعا هو يعني ده it is a number، فيعني if you know the number you will answer, if you don't know the number you will not answer right. فهو ال correct answer here is 15 to 50 milliliters of fluid اللي هي C. The normal pericardium, as we all know, is a double-layered sac. It is composed of visceral pericardium and parietal pericardium. Between them, there is a small amount of fluid, about 15 to 50 milliliters of fluid, to allow lubrication between the visceral and the parietal pericardium. So, we will proceed to the second question. Chest pain is often absent in which of the following? Post-irradiation pericarditis, neoplastic pericarditis, uremic pericarditis, or all of the above? Okay, you can start answering.
أي موضوع اللي هو بتاع حاتم الأولاني مع السيد وهبة. الموضوع أنا بقعد أقول
اوكي انا شايف ان most of the answers are towards B اللي هو chest pain will be absent in patients with neoplastic pericarditis. Okay, let's see the correct answer. All of the above. In fact, all these types of pericarditis will in all these types chest pain will be absent. Chest pain is absent in slowly developing tuberculous pericarditis, also in post-irradiation pericarditis, neoplastic pericarditis, and uremic pericarditis. So, in all these types of pericarditis, chest pain may be absent. So, to the third question. Pericardial friction rub is best heard at, it is a clinical question, at the apex, at the left lower sternal border, at the right sternal border, or all of the above. So, you can answer. So I can see that we have a consensus that the correct answer is B, left lower sternal border, and actually it is already the correct answer. pericardial friction rub is a high-pitched sound that can be heard at the lower left sternal border at the end of expiration with the patient in the upright position. Of course, it will be heard better if the patient is in the upright or leaning forward position. Okay, so the correct answer is the lower left sternal border. So question number 4. A patch of dullness on auscultation beneath the angle of the left scapula in patient with pericardial effusion is called Ohnbrugger's sign, Ewart's sign, Broadbent sign, or Epstein sign. I'm waiting for your answer. I know it is a difficult question, so we can proceed to the answer. The correct answer is the Ewart sign. So let's talk about all these signs. In our question, patch of dullness on auscultation beneath the angle of the left scapula due to compression atelectasis of the left lung base by the pericardial effusion. In patients with pericardial effusion, there may be compression on the base of the left lung, causing atelectasis of the left lung base, which will present with patch of dullness on auscultation of the left scapula. This sign is called the Ewart sign. The Ohnbrugger's sign is the epigastric prominence that can be seen in patients with marked pericardial effusion. The Broadbent sign is a retraction of the thoracic wall synchronous with the cardiac systole that is visible in the left posterior axillary line in patient with adherent pericardium, in patient, for example, with constrictive pericarditis or something causing adherence of the pericardium. The Epstein sign is the obtuseness of the cardiophrenic angle on percussion in patient with pericardial effusion. So the correct answer here, patch of dullness over the lower left, beneath the left scapula due to lung atelectasis is called, in patient with pericardial effusion, is called Ewart's sign. So question number 5. In cardiac tamponade, Pick's triad consists of all of the following except hypotension, soft or absent heart sounds, pulsus paradoxus, jugular venous distension with a prominent X descent but absent Y descent. So I'm waiting for your answer. So I can see that we have a consensus about that the correct answer is C, pulsus paradoxus. So let's see the correct answer. It is pulsus paradoxus. So Pick's triad is a clinical triad, which is a very important triad in the diagnosis of patients with cardiac tamponade. Pick's triad consists of 3 main signs: hypotension, soft or absent heart sounds, and distension of the neck veins with prominent X descent but absent Y descent. So if we have this triad of 3 signs, it is very sensitive for diagnosing cardiac tamponade. So to the next question. Pulsus paradoxus is defined as a decrease in the systolic arterial blood pressure of more than 10 millimeters with inspiration, more than 20 millimeters, more than 30, or more than 40 millimeters with inspiration. So I'm waiting for your answer. So I can see that most of us have chosen the answer number A, which is more than 10 millimeters with inspiration. So let us see the correct answer. It is A. The presence in the pulsus paradoxus is normally we can have with inspiration a decrease in systolic blood pressure, but less than 10 millimeters mercury. In pulsus paradoxus, it means decrease in the systolic blood pressure with inspiration with more than 10 millimeters mercury. Okay. So question number 7. Which of the following drugs is not indicated in treatment of idiopathic acute pericarditis? Phenylbutazone, colchicine, prednisone, or ibuprofen? So start answering, please. So I can see that some of us have chosen the answer number A, phenylbutazone, and the others have chosen the answer number C, prednisone. So let us see the correct answer. The correct answer is A. Phenylbutazone is not indicated in treatment of patients with idiopathic acute pericarditis. Of course, we know that in treating acute pericarditis, we have 2 lines of treatment. The first line of treatment is using the ibuprofen or the non-steroidals as ibuprofen plus colchicine. And the second line that we can use after that corticosteroids like prednisone. So colchicine, prednisone, and ibuprofen are lines of treatment in patients with acute pericarditis. But phenylbutazone is not one of the drugs that can be used for treatment of acute pericarditis. Okay, so to the next question. The presence of which of the following is most sensitive indicator of cardiac tamponade? Systemic arterial hypotension, tachycardia, elevated jugular venous pressure, pulsus paradoxus. So start answering, please. So I can see that we have many of us have chosen the answer A, which is systemic hypotension. Let us see the correct answer. It is D, pulsus paradoxus. Here we are talking about the most sensitive indicator of cardiac tamponade from these signs. Of course, all this can occur in patients with cardiac tamponade. Arterial hypotension, tachycardia, elevated jugular venous pressure, and pulsus paradoxus. But if we are going to choose one of them as more sensitive than the others for cardiac tamponade, it is the pulsus paradoxus. Okay. So to the next question. Plasma troponin concentrations are elevated in what percent in patients with pericarditis? 10 to 15%, 20 to 25%, 35 to 50%, or 50 to 60%? Okay, start answering, please. So I can see that some of us have chosen A and the others have chosen B. So let us see the correct answer. It is C. Well, plasma troponin concentration, we know that in patients with pericarditis, there may be involvement of the myocardium causing perimyocarditis. And this may cause elevation of the cardiac troponin, which increases the dilemma for diagnosis of patient with pericarditis and whether it is pericarditis or ischemic heart disease. There may be elevation of the cardiac troponin. In fact, in 35 to 50% of the patient, cardiac troponin may be elevated in 35 to 50% of the patients with pericarditis due to involvement of the myocardium causing perimyocarditis. Okay, to the next question. In patient with rheumatoid arthritis, the pericardial fluid has which of the following features? Exudate, decreased concentrations of complement and glucose, elevated cholesterol, or all of the above? I can see that a lot of us have chosen the answer B, which is decreased concentration of complement and glucose. Okay, and only one chosen D, which is all of the above. Let's see the correct answer. The correct answer is D. In fact, in patients with rheumatoid arthritis, if the patient with rheumatoid arthritis developed pericardial effusion, the pericardial fluid will have all these features. It will be exudate, with decreased concentration of complement and glucose, and with elevated concentrations of cholesterol. So the correct answer is all of the above. Okay. So the next question. Interferon alpha is reported to be beneficial in treatment of pericarditis caused by which of the following viruses? Cytomegalovirus, Coxsackie B virus, adenovirus, or parvovirus? Okay, answer please. Okay, so I can see that who answered chose the answer C, adenovirus. So let's see the correct answer. It is B. Okay, so all these interferon alpha was reported to be beneficial in treatment of pericarditis. The only one virus of these 4 viruses that can respond to the interferon alpha is the Coxsackie B virus, not the cytomegalovirus, not the adenovirus, and not the parvovirus. Okay. So we will proceed. Now we are going to discuss some MCQs about pulmonary hypertension. Okay. This is the first one. Which of the following example of causes of pulmonary hypertension is incorrectly matched to the group classification? Group 1 pulmonary hypertension, it includes idiopathic or heritable causes of pulmonary arterial hypertension. Group 2 pulmonary hypertension, degenerative mitral valve disease causing left side heart failure. Group 3 pulmonary hypertension, congenital heart disease with left right shunt. And group 4 pulmonary hypertension, pulmonary thromboembolism. So I can see that we already started answering. So I think it is one of the easy questions. Most of us or all of us have chosen the answer C. Let's see the correct answer. It is C, in fact. All of us know the classification of pulmonary hypertension. Group 1, it includes the patient with pulmonary arterial hypertension. Group 2, it includes the patient with pulmonary hypertension due to left side heart disease. Group 3, it includes the pulmonary hypertension with chronic hypoxic lung diseases. In group 4, it includes pulmonary hypertension due to thromboembolism. And the group 5 is the multifactorial pulmonary hypertension. Okay. So to the second question. A 70-year-old woman with a history of proven recurrent pulmonary emboli, but no other comorbidities, presents with shortness of breath over a number of months. Her INR has been within the therapeutic range. Serial echocardiograms demonstrated persistent features of pulmonary hypertension. So we have a female with history of pulmonary embolism, and she is on warfarin, and her INR is in the therapeutic range, and her echocardiogram is showing features of pulmonary hypertension, and she is presenting with shortness of breath. Which of the following is the most important measure? Persist with warfarin, the clot will resolve eventually. Refer her for consideration of pulmonary end arterectomy, change her anticoagulant, or refer her for balloon atrial septostomy. So I'm waiting for your answers. So I can see a consensus that the correct answer is B. Refer here for consideration of pulmonary end arterectomy. So let's see the correct answer. It is B. Actually, in patient with pulmonary hypertension, which is group 4, the thromboembolic pulmonary hypertension, in these patients, pulmonary end arterectomy is considered the curative for them. So if the patient, of course, the first line of treatment is anticoagulation. But if the patient is persistent on the anticoagulation and her symptoms are not improving, she must be offered the chance for having pulmonary end arterectomy and weighing the benefits and the risk of the surgery. Of course, it is a huge surgery and carries a high mortality risk, but on the other hand, it is a curative surgery. Okay. Regarding balloon atrial septostomy, it allows like a vent between the left atrium and the right atrium to try to decrease the patient symptoms or improve the patient symptoms if the patient is not candidate for pulmonary end arterectomy. But first, we have to consider the option of pulmonary end arterectomy, and if the patient is fit, she must do it. Okay. To the next question. So you are managing a patient admitted with worsening heart failure symptoms. She has been diagnosed with idiopathic pulmonary arterial hypertension and receives continuous intravenous epoprostenol infusion. Which of the following is true? Interruption to the infusion can be tolerated for hours. Redness around the line of infusion site is expected. Treatment with this agent would have been started when the patient was in NIA class 3 or 4. This treatment will not be used in combination with other advanced therapies. So I am waiting for your answers. So the correct answer here is C. Treatment with this agent would have been started when the patient was in NIHA class 3 or 4. So let us revise some data about the use of intravenous epoprostenol in patients with idiopathic pulmonary hypertension. Intravenous epoprostenol is a prostacyclin analog, and it is the only therapy till now that has a proven mortality benefit by randomized controlled trials. Okay, epoprostenol is indicated in patients who are in NIHA class 3 and or are deteriorating in NIHA class 4, and is often used, and it can be used in combination with other drugs. Of course, interruption of the infusion of epoprostenol is not indicated or must not be allowed, because it will produce reverse effects. And also presence of redness around the line of entry, it indicates the presence of infection, which must be managed immediately, and it must not be taken lightly. Okay, so to the next question. Which one of the following factors is considered high risk in a patient with pulmonary arterial hypertension? A 6-minute walk distance more than 380 meters, peak oxygen consumption less than 11 milliliter per minute per kilogram, normal BNP levels, right atrial pressure less than 10 millimeters mercury. So start answering, please. So I can see that we have chosen the answer B, which is the peak oxygen consumption less than 11 milliliters per minute per kilogram. Let us see the answer. Okay, the correct answer is B. Okay, we have to know that there are some criteria which are considered high risk criteria in patients with type 1, which is the pulmonary arterial hypertension. These criteria are 6-minute walk distance less than 165 meters, peak oxygen consumption less than 11 milliliters per minute per kilogram, BNP level greater than 300 nanogram per liter, and right atrial pressure more than 14 millimeters mercury. Okay, these are the high risk criteria. Okay, to the next question. With respect to pulmonary hypertension patients with congenital heart disease, which of the following is true? Pregnancy is well tolerated, making counseling unnecessary. Eisenmenger syndrome describes reversal of a right to left shunt due to development of pulmonary hypertension. Transthoracic echocardiogram inadequately images the upper septum, and so sinus venosus defects may be missed. The 6-minute walk test is a precise measure of disease severity. So I'm waiting for your answer. So here we want the true sentence. I can see that most of us have chosen the answer C. Okay, let us see the correct answer. It is C. So let's revise all these answers. Eisenmenger syndrome is defined as reversal of left to right shunt, not right to left shunt, due to development of pulmonary hypertension. The patient, at first, the patient has a left to right shunt, but due to development of the pulmonary hypertension, the shunt is reversed to become right to left shunt, which leads to the development of the Eisenmenger syndrome. Okay, a sinus venosus defect should be considered in patients with dilated right side of the heart and pulmonary hypertension, and it can be easily missed by transthoracic echo. So in these cases, if you have by transthoracic echo dilated right side in a patient with pulmonary hypertension, you have to do a transesophageal echo to exclude sinus venosus ACD, which can be easily missed by transthoracic echo. Okay, the development of pulmonary arterial hypertension in during a pregnancy is very dangerous. And in these cases, in patient with significant, if the patient is pregnant with significant pulmonary hypertension, it is a very high risk pregnancy, so it cannot be taken lightly. Regarding the 6-minute walk test, it is a precise test for it can be used for testing patients with pulmonary hypertension for the risk stratification, but it has many limitations. So the correct answer here is C. So to the next question. Regarding treatment of patients with pulmonary hypertension, which of the following is true? Acute vasoreactivity test is indicated in all patients with type 1 pulmonary arterial hypertension. Bosentan is recommended in patients with WHO function class 3 with Eisenmenger syndrome. Resting echocardiography is recommended as a screening test in asymptomatic patients with connective tissue disease, followed by annual screening with echocardiogram. Liver transplantation can be done with caution in patients with severe pulmonary arterial hypertension. So start answering, please. So let us see the correct answer. We need the true statement. The correct answer is B. Only B is the correct. Bosentan is recommended in WHO function class 3 patient with Eisenmenger syndrome. So what about the 3 other sentence? Number A, acute vasoreactivity test is indicated in all patients with type 1 pulmonary arterial hypertension. No, not indicated in all patients. It is indicated in subgroup of these patients. So C, resting echocardiography is recommended as a screening in asymptomatic patient, not with all connective tissue disease but with systemic sclerosis. Only patients with systemic sclerosis are indicated to have echocardiography at first and the annual echocardiography for screening for pulmonary arterial hypertension. So not all connective tissue diseases, only systemic sclerosis. Regarding liver transplantation, it is contraindicated in patients with severe pulmonary arterial hypertension. It cannot be done with caution. It is contraindicated. So the only sentence which is true is B. The use of bosentan in patients with Eisenmenger syndrome, function class 3. Okay. So to the next question. Which of the following statements regarding the natural history of idiopathic pulmonary arterial hypertension is true? The prevalence is equal in males and females. Chest pain due to right ventricular ischemia is the most common symptom. Sudden cardiac death is a potential complication, but only in patients with class 4 symptoms. Increased intensity of S1 is the most common physical finding. ECG evidence of right ventricular hypertrophy is present in a minority of patients. So I am waiting for your answer. So I can see that most of us have chosen the answer C. So let us see the correct answer. It is actually C. So only C is correct. Sudden cardiac death is a potential complication, but only in patient with class 4 symptoms. So let's revise some data about the natural history of pulmonary hypertension. Most of the patients were female, 63% of the patients, where the most common symptom is dyspnea, not the chest pain. Dyspnea is the most common symptom in patients with pulmonary arterial hypertension. The most common clinical finding is loud B2, not S1. And ECG evidence of right ventricular hypertrophy is found in most of the cases. About almost 90% of the patients have ECG criteria of right ventricular hypertrophy. Okay? While a sudden cardiac death occurs in about 26%, about 1/4 of the patients, and limited to the patient with class 4 symptoms. Okay? So to the next question. Riociguat is a recently approved medication that results in improving the exercise tolerance in patients with pulmonary arterial hypertension and patients with chronic thromboembolic pulmonary hypertension. The mechanism of action of Riociguat is nitric oxide donor, soluble guanylyl cyclase stimulator, heme oxygenase inhibitor, endothelin receptor antagonist. So I'm waiting for your answer. So I can see that there is a consensus that the correct answer is B. Well, it is B. So the mechanism of action of Riociguat is that it is a soluble guanylyl cyclase stimulator. Okay. So the third section of our MCQ interactive MCQ session today will be some MCQs about pulmonary embolism. Okay. So we will start with the first question. A 27 years old female presented with 2 days history of shortness of breath. The plasma D dimer is elevated, and a high resolution CT chest revealed segmental pulmonary embolism, and the venous duplex showed deep venous thrombosis in the right femoral vein. She denies any recent travel, immobilization, or surgery. Which of the following primary hypercoagulable states is the most frequent among patients who present with DVT and pulmonary embolism? Protein C deficiency, activated protein C resistance, prothrombin gene mutation, or protein S deficiency? So start answering, please. So I can see that we don't have a consensus about the correct answer. Let's see the correct answer. The correct answer is B. Okay. So primary hypercoagulable states must be suspected in patients presenting with deep venous thrombosis in absence of identifiable predisposing factors. The activated protein C resistance, which is also known as factor V Leiden mutation, is found to be was found in 20% of the patient of unselected cases of deep venous thrombosis. Protein C deficiency was found in only 2 to 4 patients, 2 to 4% of the patients. Protein S deficiency in 2 to 5% of the patients, and prothrombin gene mutation in 5 to 8% of the patients. So the most common hypercoagulable state in patients presenting with DVT and pulmonary embolism is the activated protein C resistance, or which is also called factor V Leiden mutation. So to the next question. A 78 years old man presented with shortness of breath for 3 days after a 12 hours flight. His blood pressure was 128/76. His heart rate was 92 beats per minute and regular. His oxygen saturation was 96%. His weight was 78 kilograms. There is no jugular venous distension. The chest is clear and no tenderness in the calf muscle. The D dimer was elevated, and so imaging of the chest showed segmental pulmonary embolism and DVT in the left femoral vein. There are no echocardiographic signs of right ventricular strain, and his creatinine is 1. His current treatment is atorvastatin 20 mg and lisinopril 10 mg. Which of the following is the best initial treatment strategy? Enoxaparin 1 mg per kilogram subcutaneous once, then warfarin with an INR 2 to 3, dabigatran 150 mg twice, rivaroxaban 20 mg once, or apixaban 10 mg twice for 7 days, then 5 mg twice daily. So I'm waiting for your answer. So I can see that the majority have chosen the answer D, which is apixaban 10 mg twice daily for 7 days, then 5 mg twice daily. So let us see the correct answer. The correct answer is D. So let's revise the case slowly. Here we are having a male patient which is having provoked DVT and pulmonary embolism. So we have a sure diagnosis of DVT and pulmonary embolism by imaging. The patient is vitally stable. So we are having a patient with pulmonary embolism and DVT and vitally stable. His blood pressure is okay. His heart rate is okay. His oxygen saturation is okay. So we are having a stable patient with DVT and pulmonary embolism. So in this case, we have the option to treat this patient with oral medication with the NOACs. Okay. So if we are revising the options of NOACs in our patient, we have the dabigatran, the rivaroxaban, or the apixaban. Regarding the dabigatran, it cannot be started immediately in patient with pulmonary embolism. It has to be started after the patient take enoxaparin. So the patient will take enoxaparin first. Okay, the patient will take enoxaparin first for 5 days, and then the patient can start the dabigatran. If we are talking about the rivaroxaban, the patient at first starts with 15 milligrams twice for 21 days, and then continue on rivaroxaban 20 milligrams daily. The patient doesn't start from the start with 20 milligrams daily. Regarding apixaban, the patient can start with 10 milligrams twice daily for 7 days, and then continue on the regular dose 5 milligrams twice daily. So the correct answer here will be apixaban. So to the next question. All the following are considered high-risk predisposing factors for pulmonary embolism except fracture of the lower limbs, hospitalization for heart failure or atrial flutter or fibrillation in the previous 3 months, postpartum period, spinal cord injury, hip or knee replacement. So answer please. So I can see that we are talking about either B or C. Some of us choosing B and the others choosing C. Let us see the correct answer. The correct answer is C. So features of high-risk features for pulmonary or high-risk predisposing factors for pulmonary embolism includes fracture of the lower limb, hospitalization for heart failure or atrial fibrillation, hip or knee replacement, major trauma, myocardial infarction, previous venous thromboembolism, and spinal cord injury. Postpartum period is a moderate or intermediate risk predisposing factor for pulmonary embolism. Okay, so to the next question. For a patient with suspected pulmonary embolism and shock, which of the following is the least appropriate strategy? Least appropriate. Thrombolytic therapy if cardiogenic shock is present. Initiation of anticoagulation treatment while diagnostic workup is ongoing. CT angiography if cardiogenic shock. D-dimer level measurements if shock. Bedside transthoracic echocardiography. And if the patient is in cardiogenic shock and CT is not immediately available. So I'm waiting for your answers. So I can see that some of us have chosen C and others have chosen D. Pay attention that we are talking about the step that we don't want to do, the least appropriate strategy. Okay, so let's see the correct answer. The correct answer is D. Well, in patient with pulmonary embolism presenting with cardiogenic shock, D-dimer measurement is not indicated. So if we revise the algorithm for management of patient with pulmonary embolism, if the patient is presenting with pulmonary embolism and hemodynamic instability, so the first step is to do a bedside transthoracic echo, and then we can do, if the patient, if we have an available and rapid CT, we are going to do CT pulmonary angiography. But there is no place for the D-dimer in the algorithm. But if the patient is presenting with pulmonary embolism without hemodynamic instability, here the D-dimer will play an important role in the diagnosis and in proceeding for management. So we have to pay attention that if the patient is presenting with pulmonary embolism and hemodynamic instability, we only have the bedside transthoracic echo and CT pulmonary angiography if it is rapid available. The D-dimer does not play a role in the diagnosis if the patient is hemodynamically unstable. Okay, so to the next question. Regarding management of acute pulmonary embolism during pregnancy, which of the following is not true? Not true. Thrombolysis or surgical embolectomy should be considered for pregnant females with high-risk pulmonary embolism. Low molecular weight heparin is the recommended therapy for pulmonary embolism in the majority of pregnant women without hemodynamic instability. Insertion of a spinal or epidural needle is not recommended unless more than or equal to 12 hours have passed since the last therapeutic dose of low molecular weight heparin. NOACs are not recommended during a pregnancy or lactation. So answer please. So I can see that the majority of us have chosen C. So let us see the correct answer. It is C. So why C is not true? If we revise the guidelines, we can see that insertion of a spinal or epidural needle is not recommended except if it has passed more than or equal to 24 hours from the last therapeutic dose of low molecular weight heparin. Not 12 hours, it is 24 hours. Okay. So to the next question. Regarding management of acute pulmonary embolism in patient with active cancer, which of the following is not true? Low molecular weight heparin should be considered in the first 6 months. Riociguat should be considered as an alternative to weight-adjusted doses of subcutaneous low molecular weight heparin in all patients with cancer. edoxaban should be considered as an alternative to weight-adjusted subcutaneous low molecular weight heparin in patients without gastrointestinal cancer. Extended anticoagulation beyond the first 6 months should be considered for an indefinite period or until the cancer is cured. So I can see that we have a consensus that the correct answer or the incorrect statement here is B. So let us see the answer. It is B. Well, if we revise the guidelines, we can find that rivaroxaban should be considered as an alternative to low molecular weight heparin in patients with pulmonary embolism and cancer, but not gastrointestinal cancer. Not all patients with cancer. Patient with cancer except patient with GIT cancer, because it carries in patient with GIT cancer, it carries increased risk of increased bleeding. Okay. Now we came to the end of our interactive MCQ session. I hope we have discussed multiple aspects regarding the our three subjects: pulmonary hypertension, pulmonary embolism, and pericardial diseases. Okay, and I wish you luck in the coming exams and كل سنة وانتم طيبين.